Chitrakala is done.
Yes, sir.
Okay, thank you. Oh, ma'am, with your permission, shall I start?
Yeah, we'll start.
Thank you, ma'am. Good evening, doctors. This is Dr. Sumeshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I request all the delegates to please do comment your questions in the comment box so that at the end of the webinar we'll have a short Q&A session. So now let me welcome our today's eminent speaker, Dr. Narmada Hadikal Mam, who have done her medicine from OMC and DGO from GMC and DNB from MNMS and DPHA, and she's a laparoscopic and hysteroscopy surgeon and fertility specialist. She worked as a professor in Usmania and Gandhi hospitals for many years and started her career as an obstetrician in Iran for Ministry of Health for 7 years and did research in high-risk pregnancy in USA, Atlanta as a gynecologist and obstetrician. She has experience over 3 decades. Her fields of interest are vaginal surgeries, endoscopic surgeries, and she has trained many doctors in the same field. She is a member of ALSO and Advisory Board USA, and she gives training to doctors and emergency medical workers in Emergency Medical and Research Institute, Telangana government. And presently, she is working as a medical director for Narmada Fertility and Endoscopy Center, Mahindra Health, Maratpalli, Secunderabad, and also consultant gynecologist to various hospitals in Secunderabad. And with this, we welcome you for today's webinar, ma'am. And today's webinar is presented through Shield Connect, which is a digital platform of Shield. I request all the delegates please do visit Shield Connect for all the webinars, and also if you miss any part of the program, it will be available in the Shield Connect. And also we have awareness pages regarding COVID, infertility, regarding PCOS and various diseases in the obs and gynec and fertility specialties. So with this, coming to the today's topic, as we know that male infertility is becoming a very challenging, and in infertility, it also accounts for the 1/3 of the patients have a male infertility. So with the raising concern, there is a indeed essentiality in diagnosis and treating the male infertility has become a very big challenge. So without wasting much time, let me turn over the time to Dr. Namrata Madam to talk on male infertility, its causes and treatment options. Over to you, ma'am.
Yeah, thank you for your kind introduction. Good evening, doctors and friends. Today we are going to discuss about male infertility on this Shield platform. And last 2 decades, and we found that the male male infertility is also major contributing factor in infertility. Before almost 2 decades, and everybody used to blame the female partner about the infertility. So here nowadays, whenever you visit these infertility clinics, you see male members are more than female patients. So it has become that male infertility has become the major challenge, and we have to treat with all precautions and all factors we have to take into consideration and do. Because if female patient is infertile, we can do laparoscopy, hysteroscopy, and remove some problems. Like if tubal blockage is there, if myomas are there, we can solve those problems by doing surgery and other investigations. But in male infertility, the problem is where to start. And most of the times, unknown causes are more and blockages are more. They are very sensitive. Because the anatomy is very difficult to approach for the male infertility patients. And long ago, few decades ago, and Dr. Stepoy and Dr. Edwards, they have invented IVF to treat bilateral tubal blockage in female patients. But this is very useful. That system, and I mean IVF and Xc, it is very useful for female partners now. Female patients, it is more useful rather than female patients, and it is more useful for male patients now. So we will today we will discuss. Is it moving? Hello? Hello?
Yeah, Madam Garu.
Yeah. Just I want to go down. It is not moving. Slide. Otherwise, you can slides.
1 second.
My slide is not moving. Till now, it was moving well.
Give me just a few seconds, ma'am.
Any problem? Okay. 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 So today we will discuss about what is the definition, epidemiology, what are the causes and factors, and what are the complications, evaluation, and how to evaluate basic investigations, and what are the semen parameters, and other things we will discuss about in detail, like in ART techniques and other medical therapy, how to treat them, and surgical therapy also. So infertility, and it is an old definition, of course, the WHO definition, inability to conceive after having normal sexual intercourse for 1 year and with the sexual partner. And it is again primary infertility and secondary infertility. So whatever it is, the epidemiology is like this. Almost 1/3 of this male, 33% of these factors are responsible. Infertility is responsible for the male fertility, only male fertility, and 25% both male and female together, and another 25% only female partners are responsible for this, and 7% is unknown factors. So coming to the male fertility, refers to male inability to have pregnancy in the female partner. So coming in this epidemiology, and just now we have discussed about combined factors are also there, and in 50% of involuntary childless couples, a male infertility associated factor is found, usually together with abnormal semen parameters. So we will discuss semen parameters in detail. So later, and coming to this normal spermatogenesis, and it takes nearly about 72 days to start this spermatogenesis. Nearly daily, about 120 million of sperms are producing in the seminiferous tubules. Here, in these patients, Normospermia is 35%. Oligospermia. In oligospermia, we have mild oligospermia, which is less than 15 million count, and severe oligospermia which is less than 5 million. This percentage. So, asthenoteratospermia and azospermia means no sperms. We will discuss this in detail. So, what are the problems that causing the male infertility? So male genital tract, the sperm has to produce in the testis. From there, it has to travel long way to this epididymis. From epididymis, again, it has to go to this with the help of that seminal vesicle, and it will form ejaculatory duct. From there, it will go and enter into the bulbous urethra, and from there it will emission will done. So here we have structural abnormalities, sperm production disorders, and ejaculatory disorders, and which are dependent on psychological factors and neurological factors. Of course, immunological factors contribute a lot. So these are what are the main causes of infertility. So coming to here, again, like in female, hypothalamo-gonadal axis, hypothalamus will release GnRH. From there, it will stimulate FSH and LH. And from there, on testis, seminiferous tubules will produce, with the help of the sertolized cells, they produce sperms. But these sertolized cells are there in the intraluminal part of the seminiferous tubule, and outside extraluminal, and will be influenced by the LH. LH will stimulate the production of the testosterone, and as well as some part of estrogen is also produced by the Leydig cells. And with the help of one protein, immunoglobulin and protein, and this androgen will be taken from outside into the intraluminal part to enhance the production of and to activate these sperms. And from there, all sperms will collect in the epididymis. In epididymis, and some part of maturation is again it will occur, and unless until these sperms go into the female genital tract in vagina, and from there it goes to the uterus, from there it goes to the fallopian tube. There the main part is capacitation. Capacitation of the sperm is nothing but the hypermotility of the sperm, and also acromial action, acrosome action. Acrosome is nothing but which is laid on the head of the sperm, and it will act, and it will release some hormones and enzymes, and it will fertilize the egg naturally. So in male infertility, of course, unexplained is 34%, and cryptorchism is also very much high, and it is about 8%. And coming to the other thing, hypogonadism. Hypogonadism means this hypothalamo-pituitary axis problems like congenital or acquired problems are there. And of course, the urogenital infections like urethral infections, bladder infections, sexual disorders, I mean infections, VDRL problems, and other sexual ejaculation and emission problems are also there. And here, and again, one more important thing we have to discuss is the varicocele. Varicocele is more common in male, but the varicocele, it is in every patient of varicocele, the infertility will not occur. Only in some patients, whenever we see the semen analysis, if it is abnormal, then only they have to undergo treatment. Otherwise, patient is having varicocele and normal semen analysis, they need not undergo any kind of treatment. So main causes of infertility. This I would like to rather just divide like this: pretesticular, testicular, and post-testicular causes of the infertility. Coming to the pretesticular, it is always hypothalamo-pituitary axis problems like pituitary insufficiency and pituitary tumors and chronic illnesses like if patient is on some illicit drugs and too much of alcoholism, and Kalman syndrome. Kalman syndrome is nothing but some part of the pituitary cells will not develop properly, so it will not secrete GnRH, and when there is no GnRH, LSH, FSH and LH will not produce from the pituitary. So next, testicular disorders, and what are the problems in the test, like any infection in the testis, testicular atrophy, like in Klinefelter syndrome, we see small testes, and sexual disorders they will have. And also coming to the chromosomal deletions and Y chromosome deletions and systemic disorders and other infections are also common. So next, the seminal tract disorders, again retrograde ejaculation, and whenever there is emission of the sperm, and it has to close. That's ejaculatory duct when there is a problem, and it will go back into the urinary bladder, and retrograde. In fact, forward coming into this semen, it will go in backward. So any other things like obstructive azuspermia, autoimmunity of the sperms is also very, very common. So this obstructive azuspermia, usually the obstruction, bilateral obstruction will be there in the vas deferens, sometimes also in the ejaculatory duct. And these things we can see MRI, if you do MRI, or rectal ultrasound, if you do, we will come to know. And sometimes congenital also, apart from the acquired, congenital is also, most of the times it is very, very common. So what are the risk factors for this infertility? So precocious puberty, if they they attain puberty before 11 weeks or after 11 years or 17 years. And two extremes of pubertal age is also not good. So exposure to toxic substances like lead, cadmium, mercury, and other things are very much radiation. Whenever they take it for some treatment like testicular tumors, or when people are working in X-rays continuously. These heavy metals like lead, cadmium, mercury impairs male infertility directly or indirectly. They can exert some directly gonadotoxic effects through production of reactive oxygen species. In this testis, that induces DNA damage and ultimately leads to disruption of the spermatogenesis. Indirectly, they have the potential to compatibility binding to sex hormonal receptors, and sex steroids problem will be there. So in coming to the heavy alcohol consumption, directly it will act on the hypothalamo-pituitary axis, and it will cause gonadotoxic, and the proper release, GnRH release, and other FSH and LH hormone release will not be there. Smoking and cigarettes, and this tobacco smoking, directly it will affect on the spermatogenesis, and it will affect on the spermatogenesis and production of the this spermatozoa will decrease. What is the effect of obesity in reproductive men? I mean reproductive age in men. So obesity, in extreme obesity, what will happen? Obesity is nothing but some one syndrome kind of thing, metabolic syndrome, obesity and hyperlipidemia, and hypertension, and type 2 diabetes. All these factors.
Regarding this special
all these factors, they reduce the production of the testosterone, and especially in obesity.
The first purpose is we will have a retail push. You know why? Like for example, chemist called Farooq. Chemist named Farooq. He is buying only 5 strips of upwards of people.
Some disturbance is there. Yeah. Somebody talking on this thing. Because of in obesity, obese people, the estrogen levels are more. And estrogen, when the estrogen level is more, they will have oligospermia, either decreased motility of the sperms will be there. So what are the risk factors? So the exposing the genitalia to high temperature. When people are working in hot furnaces and in a hot climate, in factories, something like that, usually these testes, 1 degree temperature is less than the total body temperature. They stay in this scrotal sac. These both testes stay to decrease the temperature. So whenever there is a cryptorchidism, and many days those both testes will be there in the abdominal cavity, so the seminiferous tubule function will come down, it will not act. And also not only that, accidents and damage to testes and other things, and surgical injury, whenever we do hernia repairs and varicocele repair, or some this cryptorchidism problems, when they repair, and minor injury to the vas can occur, and the problem will be there, and obstruction will form. So heavy trauma and being born with fertility disorders, medical condition, just now we have discussed in metabolic syndrome like diabetes, and in sickle cell anemia also the problem will be there. And radiation will affect directly on the seminiferous tubule function, and damage to the semen will, sperms will occur. So what are the risk factors? Thermal toxicity and radiation, cell phone use. And regarding the cell phone use, and directly there is a problem on sperm count, motility, viability, and morphology also. So of course, infections and inflammations, sexually transmitted diseases, and all parts of genital tract, like right from the urethra, next prostate gland, and testis, epididymis, and all these things, they affected by the various bacteria, viruses, and other fungal things. So all these things we have to look into thing, and especially these testes, they affected by rubella virus and mumps. So some Coxsackie viruses, gonorrhea, and E. coli, staphylococcus, streptococcus. Of course, the gonorrhea is the incidence of gonorrhea is decreased now, but chlamydia is in the higher side, and which is very bad for the female partner rather than the male partner. And tuberculosis, Mycobacterium tuberculosis, is very much common in reproductive. The effect is more on the reproductive organ, and it will cause scarring and destruction of the epididymis and vas deferens. So what are the complications? And of course, they will have a lot of social stress and emotional stress, expensive treatment. They have to take help from the doctor and other things, and socially they have to face the social stigma and other things. And if female partner is there, if something is there, they can accept, but in male partner it is very difficult to convince that if they are not having any sperm count, proper sperm count, or azuspermia, they offend most compared to female partners. So because of the cryptorchism and other things, they may have increased chances of the testicular cancers and other things. So how to evaluate these patients? And history is very, very important, and physical examination is also very important. And whenever patient is coming into the clinical OP clinically, and by seeing in one side, we can imagine what is the height of that patient, whether he is obese, and beard and mustache are developed properly, whether he is having any gynecomastia, and other things, and obesity, and is too obese and is too tall to exclude any abnormalities, congenital abnormalities or genetic abnormalities, these things. And proper history taking is also very important. If patient is suffering with the azuspermia, we have to take history of the infections, previous infections like mumps, measles, and other infection history we should take, and sexual performances, how frequently they are meeting with their partner and other things, any previous operations, or what is the proper occupation is very, very important. And I have seen many patients that where people are working in the fields, and they will be doing pesticide pesticidal to all these fields and other things, and they have a lot of problem. They face a lot of problems. Previously, they will have one baby, and after some time, the azuspermia, we found that the patient is suffering with the azuspermia. So these things we should elicit. Occupation is very, very important, and also habits. How many, suppose if they are smoking, how many cigarettes they are smoking per day, and how many times they drink per week. All these things in detail we have to take the history, and physical examination is very, very important. We have to we have to see the weight and other things. And any patient is suffering with any smell problem, any visual problem, all these things we have to see. And virilization and gynecomastia, of course, we have to see. And scrotal examination is very, very important. By doing scrotal examination, we can just exclude the varicocele, as well as we can palpate the epididymis and vas in the inguinal region also. in scrotal to inguinal region, we can palpate, and other testicular size. If it is too small, infantile testis and those things also, see whether the testes are absent in the scrotal sac or not, but urologist and those people will see. And varicocele, of course, there are grades of varicocele, 1, 2, 3. Depending upon the semen analysis, we have to subject them for the treatment. And what are the basic investigations? Of course, semen analysis is the foremost and important thing, and it is very cheap and easily available to do anywhere in the lab and or in the clinic. So in semen analysis, we have to, in detail, we will discuss concentration, motility and morphology, antibodies and other things. Hormonal measurements, of course, we have to do some hormonal measurements like LH, FSH, prolactin and testosterone, and sex hormone binding globulin. And whenever you suspect that some problem is there, like azuspermia or varicocele, we have to do scrotal ultrasound and transrectal ultrasound to exclude any prostate or seminal vesicle problems, MRI. And if you suspect some micro or macroadenoma, patient is having some hyperprolactinemia, better to do MRI of the pituitary. And when patient is having this azuspermia, better to do biopsy, open or closed biopsy. Testicular biopsy is mandatory to tell them that it is azuspermia is proven. So these first step, just we have discussed about semen analysis, and the main thing, how to collect that semen is very important, and they should have abstinence for 2 to 3 days before collection, and it has to be collected by masturbation, and they are not supposed to get it from the home, and within half an hour we have to see, and they should collect in the sterile wide mouth open box. So what is a nomenclature? And this is aspermia is no sperm, and oligospermia, we just now we discussed that is if it is less than 15 million, it is oligospermia. Severe oligospermia means less than 5 million per ml. Azuspermia means no sperms at all, will not be seen in the semen. Asthenospermia is reduced motility. Necrozuspermia is dead or motionless sperms will be seen. And tetrazuspermia means abnormal morphology. More than 70% of abnormal morphology is there, it is there. So everything will be there. Oligo, asthenos, tetrazuspermia, disturbance in the all 3 varieties will be there. So once we just see that how much volume we have to see, what is the appearance, whether any yellow in color means some infection, blood is there, some problem, infection kind of thing, and color, liquefaction, it has to liquefy within half an hour of the collection, and viscosity, of course, pH is very, very important. pH is seminal pH is always alkaline. The contribution is from the seminal vesicle, and microscopic appearance, concentration, motility, morphology, and pus cells and agglutination reactions, everything we should see. And here we can see the head, the sperm. The sperm here, it is 60 millimeters, and it contains head, neck, and tail. And head contains the nucleus, and this is the acrosomal cap. It is very important for the fertilization. Here DNA and RNA will be there, and here this is the black box. Here the mitochondria will be there. This is the black box of the sperm, and this is the Golgi apparatus, and it secretes some hormones and other things. And this tail is also divided into the principal piece, middle piece, and the terminal tail. And these are the things. And here we have seen the concentration, motility, agglutination, other thing. And in detail, we can see reactive oxygen species and oxygen reduction potentials, other things we will discuss later. And if there is any problem, like a genetic problem, we can see through doing this aneuploidies and other things. Fish technique and chromatin condensation technique also we can do. So this is the volume, and it should be, and actually this semen analysis in WHO, they have decided only in 2010, almost 10 years ago. And there was hardly any 10 years difference they did, and again the standards they have not recorded, and the volume will be 1.5 ml, and concentration should be minimum 15, and total sperm count should be minimum 39. It is 36 to 42 actually, so they have taken it as average. So total motility should be at least 40%, and progressive motility is very, very important. 32% at least it should be there. And the important thing is vitality, and whether 58% should alive. And morphology is very, very important. It is a basic thing that at least 4% normal morphology should be there. And of course, these pus cells, 1 million per ml is desirable, and if it is more than that, again problem. And CART analysis, this is a computerized analysis of the sperm, and there we can have upper range and a lower range. And so coming to the seminal pH, it is always alkaline, we discussed, and the alkaline fluid is coming from the seminal vesicle, and acidic fluid is from the prostate. The contribution is like that. So whenever and the semen is there in the vagina, vaginal environment in pH is acidic, and this semen is alkaline. Most of the sperms, they die in the vagina itself within 20 minutes because of the disturbances in the pH. Remaining, when they survive, they will just enter into the this cervical mucosa, and it will filter. The sperms will slowly go into the uterine cavity one by one. And there in vagina itself, phagocytosis and digestive, some digestive enzymes, it will, some enzymes, it will digest those sperms, and they kill the sperms. So the pH of two fluid combined, this seminal and prostate fluid, it should be 7.2 to 8.2. If it is acidic, and all sperms will die. So higher, if patient is having higher infection, that means they are having some prostatic infection, other things. Sperm basic function is to fertilize an ovum and contribute to, and contribute. It should share that part of the chromosomes. That is a main function of the sperm. So, sperm analysis is of course, it is a very important factor to know, and it has, because if the morphology is good, they can fertilize an oocyte, and DNA it can share with the oocyte, and also achieve healthy pregnancy. If the sperm is not healthy, and abortions can occur, and if at all any problem is there, implantation may not occur. And also when we do all these ART techniques, also the failure rate will be more. So what are the treatment management, general management? And we of course we always do counseling for both the partners, and we tell them what are the choices if patient is having any severe problems, and we advise them to have regarding this IVF and Xc techniques, and in if no sperm at all anywhere, and we can ask for donor inseminations and adoption, other things we can discuss with the openly. You can discuss with the patients. And if at all we are doing IVF or Xc also, what are the chances of success rate also, we should discuss openly with them. So what is the current management for subfertility and natural conception, whether it will occur or not? So what are the empirical therapies we can do? So whether we can do IUIs, intrauterine inseminations, or otherwise we can just ask them to have normal intercourse and do follicular study, and tell them about coital timings, and check the female, other things. Otherwise, consider these artificial reproductive techniques. So for the treatment of male infertility, in the case of extreme oligospermia, better they can go for Xc techniques, and complete azospermia. There are we can take sperms from the testis and directly from the testis or from the epididymis. And azospermia, maybe if you have to think that is obstructive azospermia. In those cases, we can take directly sperms from the testis, and low volume ejaculate, and we can collect that ejaculate and freeze and again search for sperms and other things. And if patient is suffering from the ejaculatory defects, and counseling should be done, and some medication we can give. If patient is too much of obese and other problems like smoking, heavy drinking and other things, we can counsel them, and we can give some time to control all those things and treat them. And in hypogonadism, usually what we can give them some pure FSH HMG, and twice in a week, and we can even stimulate with the HCG 5000 international units intramuscularly once in a week or twice in a week. And pulsatile GnRH therapy, and because in Kallmann syndrome, when there is absence of GnRH, we can slowly stimulate the pituitary by giving this GnRH in the small doses, so that the GnRH will again stimulate the pituitary, and FSH and LH will be produced. So hypogonadism, and even we can give this clomiphene citrate 25 milligrams for 3 months, and you can give gap of 1 month. Again, you can start this clomiphene citrate for another 3 months. The dosage is less compared to female partners, and it will clomiphene citrate will stimulate FSH, LH, and testosterone. But one thing, testosterone is not a treatment of choice in male infertility unless until it is proved that low levels are there. And I have seen people giving testosterone heavy doses, and that will decrease the actually central axis, and that will decrease the GnRH, and further damage will be there. And if patient is suffering with the infection, we can give doxycycline, erythromycin for 2 to 3 weeks. And if patient is suffering with the retrograde ejaculation, this alpha agonist we can give, or else we can collect that as alkaline. We can do that urine, we can make it alkaline by giving 3 days prior to their collection, whatever if they are undergoing. And in centrifuge, we can if you centrifuge the urine, we can find some sperms. If it is urine is usually acidic, so we have to make it alkaline prior to collection of these sperms. So surgical treatment is if there is any problem in vas difference, and any blockage is there, vasovasostomy can be done, vasoepididylostomy can be done, and the patient is suffering with the hydrocele or on any problem, we can do surgeries and orchiopexy in undescended cystis, and removal of that damaged testis we can do for one side. This ejaculatory fraction, usually it is psychosomatic disorder, psychosexual disorder, and we should counsel the patient. And otherwise, if there is any erectile dysfunction or anything is there, sildenafil citrate or taldafil 25 to 100 milligrams before sexual intercourse, they can have it. And these are the assisted reproductive techniques like IUI and testicular sperm extraction directly from the testis, and percutaneous epididymal sperm aspirations, and also microsurgical sperm aspirations from the epididymis we can see, and we can do Xc also. So sperm retrieval techniques, these three techniques are sperm retrieval techniques. Directly we can take under local anesthesia or spinal anesthesia. And Xc, and what is the where we have to do Xc? And Xc, it is a miracle for the male infertility, miracle treatment for the male infertility. And after 2 decades back, they found that Xc is the best technique, and here with this Xc, and all male patients are getting really good benefit with this kind of treatment. So it involves one single injection of this sperm into the ooplasm will fertilize that egg, and embryo will form. Again, we can implant in the uterine cavity. And sometimes if you don't get good sperm, and even spermatid also, they can make mature, and of course in some places even they are injecting the spermatid, and I mean directly if you take it from the testis, and it may be immature, but still fertilization will occur. Of course the chances of implantation will be less. Of course fertilization will occur, implantation may be less. And also if patient is suffering with the severe oligospermia, and less than 2 million motile sperms are there, and again Xc is the better option. And when in failed IVF, if patient some problem, if they are having with the fertilization in normal IVF, directly we can inject the sperm into the ooplasm. So in a normal IVF, next slide we will discuss artificial insemination. If patient is female patient is having any problem with the cervical mucus, that is thick cervical mucus, and also cervical stenosis, directly we can inject processed semen into the uterine cavity. So the main principle is we are and actually in normal sexual intercourse, the sperm has to travel for 1 day, and but here in this IUI, we are just keeping those sperms in the uterine cavity, that is near to the fallopian tube. So just we have discussed, and when there is some defect in the sperm oocyte interaction, again Xc is the better option. And how we prepare sperms for doing X-ray, and we can collect this sperm, and also we wash it, and swim up technique, and also density gradient technique, we can do it. And while doing this IUI, only 0.3 to 0.2 ml of processed semen, that is actively motile sperms, can be injected into the uterine cavity. So this procedure can be do on the next day also. And if the at least after processing these sperms, and if it is more than motile sperms are there, and more than 10 million motile sperms are there, it is good. Good. So when there is a decreased sperm motility, we can even give phosphodiesterase inhibitor also, we can give pentoxifilin kind of thing also we can give. So so this is what is the difference between the Xc and IVF. In Xc, and directly we are injecting this one sperm into the ooplasm of the egg, and we are holding with the holding needle and injecting with the injecting. Spermatozoa is gone and polar body is here, the fertilization will occur. In conventional IVF, just around oocytes, we are leaving few sperms. That's it. We need 1 million sperm to fertilize one egg. So if we are fertilizing at least 6 eggs, we should have 10 million sperms to fertilize that egg. So artificial insemination regarding donors, when patient husband other partner is not having proper sperms and other things, and artificial insemination, the donor is also taken, and for this we have to do tests and serology tests and other blood grouping, other things, and the donor has to be healthy and same ethnic group as husband. It should be sperm, and this sperm is preserved for 180 days, and again we have to do HIV and other serological tests and other things. Legally, psychologically, and other counseling should be done, and we have to take proper consent from the both the partners. Cryopreservation. Usually cryopreservation will be done in patients as well as in donors, and whenever patient is going to undergo some treatment, like if he is suffering with a testicular tumor and he has to take some radiation treatment or some medication, and so multiple times they can donate, they can give sperms, and we can cryopreserve them for many years. And it will be done in the glycerol egg yolk cryoprotectant. And if donor is whenever you are donor sperm for this Xc and other things, again we have to do serology for the patient. We have to call the patient and see HIV, HbSAg, HCV, and other tests we have to do. Even VTRL we have to do. Specific therapy, and just now we have discussed about hypogonadotropic hypogonadism in Klinefelter syndrome, and also when you see these things are less. These things are less. Gonadotropin 25 milligrams alternative we can give, apart from the even HCG also we can give, and till the testosterone comes normal. So when you see the FSH and LH is high and testosterone is low, and we have to see what is the problem. Like in hyperprolactinemias and in macroadenomas, we can do surgery, and in microadenomas, like in female partner, taberculone is the treatment of choice, 0.5 to 2 milligrams twice a week we can give and continue it. And specific therapy for genital tract infection, of course, this chlamydia and other diseases, doxycycline, other things we can give. And there is no role of steroids in immunological problems in male infertility. And in disorders of the ejaculation, we have discussed about these two medication, like previously the sinephyl citrate and other things. And if patient is suffering with the isolated testosterone deficiency, then only we have to give this testosterone injections 2000 international units twice a week. In congenital adrenal hyperplasia, of course, you can give dexamethasone 0.5 milligrams per day. And these are the things what we use in empirical therapy in male infertility, that is clomiphene citrate, HCG, FSH plus HCG, tamoxifen, and testosterone, and zinc, keratotifin, and this anti-serotonin agents, captopril, doxycycline, tetracycline, and metronidazole in infections, and FSH, naloxone, anastrozole, and indomethacin. These are empirical drugs. So, what is the role of oxidative stress in male infertility? This is a very important thing what we are going to discuss it today in the treatment of male infertility. So what is the definition of this oxidative stress? Disturbance in the balance between the production of reactive oxygen species, that is the fighting between the free radicals and antioxidant defense mechanism. This can cause tissue damage, and it can occur in any other diseases. And this oxidative stress, DNA damage is more. So this DNA damage is responsible for oxidative stress, leading causes of defective sperm functions, and RNA transcription and telomere all these chromosomal problems will occur, and congenital malformation, if at all they conceive, and baby will have some congenital malformations, and also complex neuropsychiatric disorders, autism in the babies we can see with this problem, and if at all they born, and carcinomas are very common in these children. So single DNA damage and repair is very, very important. So again, coming to this DNA, we will discuss in the DNA fragmentation test and other next slide. So oxidative stress and testicular microenvironment. So here it affects negatively in the testicular environment. This oxidative stress is and also environmental problems is more. It will affect more on male reproductive tract rather than on the female reproductive tract, because the spermatogenesis is occurring daily, and the DNA sperm DNA has to form daily. So the direct problem will be there on the motility and also on the morphology of the sperm. So what are the role of antioxidants? So systemic treatment we have to do. We have to give some antioxidants to all male patients, whoever is suffering with the oligospermia and other problems. And mainly the few antioxidants we use in this infertility is vitamin E. Vitamin E is nothing but the fertility vitamin, and nearly about 400 milligrams per day for 6 months we give. And vitamin C, and it improves the sperm quality and function. The vitamin B12, and directly it will act on DNA, RNA of the sperm, and for oligospermic patients it is really helpful. And also in asthenozoospermia, and you can give 1000 micrograms per 6 months. And folic acid, of course, it will improve the function of this sperms. And pentoxifilin to improve the microcirculation. If there is any problem in the testicular circulation, any problem in the vascular system, we can advise this. Antioxidants. What are the other antioxidants? We have many antioxidants. Of course, they work very well on male infertility compared to female infertility. Arginine, of course, it will improve the motility. Selenium, it is anti-inflammatory drug. The highest concentration is there in the prostate, and glutathione, again, it will improve the sperm motility. L-carnitine is very, very important, and important role in the metabolism, and which is the motility will be more in that epididymal part of the genital tract, and there the L-carnitine definitely will help. Coenzyme, of course, it acts on the mitochondria of that sperm, and it with that respiratory chain will activate, and good production of sperm will form. Lycopene, and this is again another antioxidants, and with the carotenoid, it will act on the it will solve the problem of this oxidative problems. And L-carnitine, it will take the fatty acids into the sperm, and it will make them energize and produce their own saturated fatty acids and other things. So whenever you see this L-carnitine is less, and decreased sperm motility will be there. So coming to the CoQs, and nowadays we are talking so much about the CoQ10 and other CoQs, and really they help on they act on mitochondria, and they will stimulate mitochondria, and with that cellular respiration will get charged, and energy production will be there. Some radicals, some free radicals like hydrogen peroxide and superoxidase mutase, and all these things will decrease after taking this CoQ. And selenium, of course, just now we discussed about this. It is there in the prostate, and it will maintain the sperm structural integrity, and it will keep the sperm morphology as good as normal in normal patients, and it will protect the sperm DNA, and it will prevent the oxidation and bad effect on the sperm, and it will act with the hydrogen peroxide and other bad free radicals. Zinc is very, very important for RNA and DNA metabolism, and other signals. It is very, very important, and especially it is there in that tail of that and sperm. So what is the importance of treating sperm DNA fragmentation? So what is the sperm DNA fragmentation? So sperm DNA fragmentation, it is a very important test for this fragmentation. So sperm chromatin disruption is the most important thing, and to treat this sperm DNA fragmentation. So how they do? And whenever, when there is some DNA fragmentation is there, that means when there is some disturbance in the DNA and the blast fertilization will not occur. If at all fertilization occurs, it will not implant. If at all it implants, abortions will occur. And if at all abortions doesn't occur, and baby will be born with the congenital anomalies. And also they found that in many generations that will continue in that male partner. So it is to see, and they do this sperm DNA fragmentation test, sperm chromatin disruption test they do. It is a novel assay test. Actually, what is the principle of this test is, after doing denaturation with the proteins and enzymes, the DNA should be in a halo shape. And if there is this destruction, fragmented DNA fragmentation is there, and it will not be there. This will be done by the fish technique. And what is the management for this DNA fragmentation? Of course, now just we have discussed a few vitamins, and so main thing, lifestyle management is very, very important. They have to take, they should reduce their stress and stop smoking and reduce alcohol intake. And antioxidants like vitamin C, vitamin E, folic acid, zinc, and selenium they should use, and they should properly undergo for a surgical treatment like varicocele is there. They have to undergo surgery, and in infections they have to use proper antibiotics. So the sperm DNA fragmentation evidences they have given, and sperms from up to 40% of infertile men have high levels of these problems. But what we should think, and in normal patients also, there are fertilized patients also, sperm DNA fragmentation is there in the seminal fluid. But whereas if patient is not conceiving, then only it is we have to take it, we have to consider it and treat the cause. Otherwise, they observed that in normal patients also they found, whoever is having children, they found that some amount of DNA fragmentation is there. So some other ingredients like vitamin D3 and glutathione peroxidase, superoxide dismutase, astaxanthin and CoQ, and all these things, they improve the DNA in the DNA, RNA, and also mitochondria directly. It will act on the head of the sperm as well as in the middle piece of the sperm, and it will go. Okay, and this one, and some astaxanthin, methionine, and CoQ, vitamin D, all these things they have given, and they notice that no significant difference of motility in some cases, but 57% of reduction seen in sperm DNA fragmentation by using these things. So coming to the conclusion, male infertility, it is means not able to start a pregnancy with his female partner, and it has many causes, and right from the hypothalamic to the up to the testicles and external environment factors and lifestyle management. And one thing is cystic fibrosis. What will happen? Ciliary motility will come down, and the sperms cannot swim properly, and again they have some blockages in the genital tract. And in those cases, in cystic fibrosis cases, they will have congenital absence of this bilateral vas deferens and other things. So history is very, very important, and investigations and treatment is very, very important in these patients. Thank you. Thank you for your patient listening, and I am very thankful to this Shield company, and they have given me the good platform and interesting topic for me, and that is male infertility. And next, if you have any questions, just put it in the box. Thank you.
Thank you very much, ma'am, for the wonderful presentation. We are very honored and learning to hear you, ma'am. If you allow me, ma'am, we'll take the questions. Yeah. Ma'am, we have a first question.
Yeah.
what are the investigation needed in male infertility?
Yes. First and foremost is semen analysis, and before that, HIV, HPV, HCV, and normally better you do even this thyroid test as well as sugar test nowadays, because after 30 years, before 30 years only, patients are developing this diabetes, type 2 or type 1 diabetes, that we have to exclude, and complete urine examination. And if you find some like pus cells in the urine and other things, we have to subject them for the culture, and you can suspect that from female genital tract, because both partners will share these infections, and proper treatment should be done. The foremost important thing is semen analysis. So after doing semen analysis, we will come to know if it is less, then we have to test, examine the male partner by the urologist or some surgeon, and testicles they have to palpate and exclude varicocele and other things. And also, if you suspect some problem, better to subject them for the ultrasonography, and there we will come to know any problem in the genital tract. In some cases, even we have to do rectal ultrasonography. By doing this rectal ultrasonography, we will come to know any obstruction in the semen and vesicle or not. Usually, we do all these tests. Thank you.
Thank you, ma'am. Ma'am, we have
egg. There we will not know, and whether everything, the sperm morphologically is normal, and all investigations will be normal. But when it is piercing, because the sperm has to pierce the cumulus cells as well as the zona pellucida of that ovum, and there the problem will be there. So sometimes, many times we don't know. Autoantibodies are there on the sperm heads. When they go go inside the female genital tract, like with the cervical mucosa, what will happen? It will act, autoantibody reactions will occur. There also, we may not get a proper idea what is the problem. In those cases, we can grade them as unexplained infertility in male. Or else, if female patient is having children with one partner and she got divorced, and with this husband, if she is not conceiving, husband is having good sperms and other things, then in those cases also we can suspect. Thank you.
Yeah, thank you very much, ma'am. Ma'am, there are no more questions from the delegates.
Okay.
If you allow me, then we'll close this webinar.
Yeah. Okay. Thank you. It was a good webinar, and thanks to you, and you did hard work to get into me.
Yeah, thank you very much, ma'am. It's our pleasure, and we are very glad to have you, ma'am. And we look forward for your continuous support for these educational activities in the further. Thank you very much, ma'am, and many thanks from the Shield team, and also thank all the delegates for their active participation. Thank you, ma'am.
Thank you.
Thank you, Madam Garu. Thank you very much.
Thanks, Andy. బాగానే అయింది ఈసారి ఏదో కరెంట్ పోకుండా
Thank you.
ఇంటర్నెట్.
Thank you. Yes.
So next time we'll do one